Welcome to week 5 of our clinical psychology class. We're having some interesting topics this week. We have chapter 14 with behavior therapy. We have, let's take a quick look here. So we have behavior therapy, chapter 14. We have chapter 15, cognitive psychotherapy and mindfulness-based therapies. And then we have chapter 16 with group and family therapy. So we start with behavior therapy, and when we talk about behavior therapy, there is actually a discussion board that you are supposed to do on that, and that is comparing 3 popular behavior therapies. And this is set up by last name, so you have to pay attention to which last name, how does your last name start with what letter, and then you may either be in the group of people that are discussing exposure therapies. There might be one group discussing systematic desensitization, and then there's one group of us that is discussing assertiveness training. So that would be an interesting discussion, I think. And so when we talk about behavior therapy, there is, of course, a couple sort of basic systems here in terms of belief, and one is classical conditioning, which is sort of like a little bit more based on Ivan Pavlov. And the idea here is that when an unconditioned stimulus happens with a conditioned stimulus, that they become associated with each other to the point that the previously unconditioned stimulus can now be evoked by, the original stimulus. So what I see is that you can think of it that our brain velcros things together. Like I think of it like a bunny, a scared bunny is velcroed to some kind of experience, and a client will start expecting these unpleasant, uncomfortable experiences based on a situation that they're experiencing that does not necessarily originally warrant that, and so this can happen in a traumatic situation or just something, especially with panic disorder. I find with clients that had like the occurrence of a panic attack in a certain situation, that they start associating, getting conditioned that that environment where they had, or the situation where they had the panic attack, with panic attacks. So then they have anticipatory anxiety about that situation, and then in order to avoid this horrible panic attack feeling, they will avoid these situations. And so that little by little by little, that can really eliminate lots of situations in one's life due to this association. So that's a useful concept to understand. So then on the other hand, when we talk about Skinner, here is our friend B.F. Skinner and operational condition. So the idea is that the consequences of our behaviors will then drive the recurrence of those behaviors, right? And so, so there is, the advantage is that this is very empiricism based. Problems are defined very specifically. To me, it lacks the context. However, this is something that is very useful as tools. So, for example, when we look at, I don't know if you're familiar with Super Nanny, but here's a page that I found, which is called JoeFrost.com techniques, where Joe Frost puts some of her techniques on. And when you look at them, a lot of them are based on behavioral techniques and concepts. And certainly for me, when I was a behavior consultant before I became a psychologist, and I worked a lot with schools, behavioral principles and, rewards and, economies, token economies, all of that, very helpful tools in terms of managing the classroom. So I certainly appreciate that. One of the big useful techniques, of course, is systematic desensitization, which you can think of as stepwise exposure with the help of relaxation strategies. So the systematic exposure without necessarily the relaxation technique might not really work, in my opinion. So you see that, a child is exposed, maybe there's somebody has a spider, arachnophobia, and so you make a hierarchy of exposure, maybe a picture far away, a picture up close, etc. So you can, you build a hierarchy with the client after you explore sort of what the fear is. And then you go into the remote small exposure with the help of the relaxation technique. You then eliminate that anxiety reaction. And so I always say, like, desensitization is unvelcroing, what has become sort of like the stimulus that should not really elicit this kind of panic or anxiety response. This is very helpful at a client who was just so anxious that she could only lay in her dorm room on her right side because she had just gotten so panicked and associated so many things with the panic feeling that, we used some very small systematic steps in her life in some other areas, even just to kind of experience that you can have some of that emotional regulation through systematic desensitization. So there is actually, even if you're not a behaviorist, you can certainly use some of these strategies and adopt them, even if your therapy approach is different. I found this article on personalized exposure therapy, a person-centered transdiagnostic approach. So here is somebody that comes from like a humanist, client-centered approach, and they're still building in the exposure therapy and desensitization into what fits their framework. So that's awesome. It's very, very good. So cognitive therapy, on the other hand, let's take a look at this. That is really an attempt to revise cognitions, right? For example, somebody with an anxiety problem, they often kind of just like think, what if this happens? What if that happens? So the what if is a real good giveaway for a cognition that's associated with anxiety, right? With depression, oftentimes the cognition is sort of like, it's no use, it'll never help, it never gets better. So there are some specific cognitions that you can observe in your clients. And the ABC model in cognitive therapy helps us to look at what activates this thought, and that, some activating circumstance, situation, experience that then prompts certain beliefs, right? Like, it can never get better. And then it has emotional consequences, which may be deepening the depression. And so here's something where you're supposed to write a 4 to 5 page paper about the history of major cognitive therapies. And the first couple that you're supposed to write about are Albert Ellis and Aaron Beck. And then you're supposed to pick 2 of the 3 third wave therapies, specifically the ACT, which is acceptance commitment therapy, and on the other hand, DBT, which is dialectic behavior therapy. And I have to tell you that acceptance-based and mindfulness strategies fit into this little system that I told you before, is right. Explore who you are, find an acceptance of it, and then make it work for you, right? So group and family therapy is extremely helpful. And I mentioned to you before that I believe, and there's certain research that supports that for adolescents, group therapy is actually a little bit more effective than just sitting with a therapist, because if you're, adolescents are peer related, right? So there is, here is evaluating the effectiveness of child and adolescent group treatment. There's a meta-analytic review where they look at quite a bit of research, and they find that there is an effective, it's an advantage to doing the group therapy there. And so I want to mention to you the Adolescent Day Hospital. That's not mentioned at all in the book. And it's certainly a multi-systemic approach to treating adolescents in a group setting where they come, instead of going into a remote psychiatric hospital, they stay in their environment, but they come during the day and have extensive therapy in the group. And the families are involved, and oftentimes there's a school involvement. So that combines the multisystemic and the group therapy in a community setting. And so that's extremely effective and interesting. Family systems, if you are working with young children and with adolescents, it's always important to involve the family. I even would go so far as making a home visit if I work with a child client, and I certainly would work with a school. So, but that's just my viewpoint. I hope that you enjoy this week. As always, contact me if you have any questions, and have a good week.